Good morning, everybody, and thank you for joining us for this event today. Um, my name is Fatai Ogunayi, and I am a public health registrar in West Midlands. My colleagues, Beth and Helen, who will be co-hosting today's event, will be introducing themselves shortly. But first, I thought it was really key that we emphasize that thank you to everyone who has joined this event, especially given how busy we all have been and still is for the last 9 months or so. For some of us in our public health careers, we've never seen anything like this pandemic. So a really big thank you from me, from all of us, for taking time out of busy days to participate in this um, very important discussion. Why have we decided to do this session? Um, all of us would know the story of George Floyd. Some of us would have seen the horrific video clip of George Floyd's murder earlier in the year. A few of us may have experienced firsthand racism that spans the spectrum right from sort of the politely subtle element of it to right in your face, get out of my country, that I was shouted at Tottenham Road just 3 years or so ago. And so I still remember the first time I saw the clip of George Floyd and the deep pain that I felt within me, thinking this can't be real in 2020. And sadly, it was. We've seen the waves of Black Lives Matter protests that took place right across the world, and we are still seeing the deeply rooted inequalities, racism that exist in our society being revealed and brought to light by COVID pandemic. So we felt that it was a crucial time to consider anti-racism within our own public health practice. Many of us will have attended sessions on inequalities throughout our career, but they are often broad in nature and just refer to ethnicity as a risk factor rather than challenging why racial inequalities, injustices exist. And I mean really challenging that in depth. Look, I can't pretend we'll solve all of these issues in the next 4 to 5 hours. It's not realistic. But hopefully, what we can do is establish a platform that we can build on as we collectively challenge anti racism in our society and in our public health practice. So, what I'd like to do now is introduce and invite my colleague Helen to introduce herself and give us an outline of the day's agenda. Thank you. We can't hear you, Helen.
There we go. Can you hear me? Yes, brilliant. So yes, just add my thanks to everybody for coming and for being so enthusiastic about joining us for today. I think you can see the programme. Maggie Ray, FPH President and Training Programme Director for the Southwest, will be speaking next. And thank you, Maggie, for your support in getting today set up. Then we'll be going into a keynote address from Professor Kevin Fenton, the Regional Director for London Public Health England. Then there'll be some workshops, which hopefully everybody will have signed up to already. So they're intersectionality, theory and practice, unconscious bias, recognise it in ourselves, challenging, moving forward, diversifying our workforce and inclusive practices and empowered communities. Then we're going to have a short 15-minute break. And then we'll be repeating the workshops so everybody can hopefully swap over. And then we have our second address from Dr. Nisreen Alwan about anti-racism in public health and reflections on language and actions. And then we'll have a closing session at the end, summary of workshops, launch of a SIG and the chair's closing remarks. With regards to the workshops, we are a real mixture. This is a real registrar-led event. We're a real mixture of people delivering the workshops who are real subject experts who really know a lot about what they're going to deliver, whereas others are people who are joining the learning, and it's an opportunity for us all to learn together and move the agenda forward. I've just asked everyone to be quite flexible too, because it's been quite a challenging time to put together an event like this, because as Fatai said, this is, I never recall anything as busy and as challenging as this time for public health. So we've all been working around the clock. Everyone has been working around the clock. So thank you to everybody who's helped out, because it's not been an easy task to do. But we're really glad you're here and hope that you can all give this subject the attention that it deserves. And I'm now going to hand over to Beth.
Sorry, just trying and failing to unmute myself there. Hope you can all hear me okay. So I am just going to say something briefly about a few bits of admin and logistics for the morning. So as you're all aware, we're all on Zoom. So there is a chat functionality on Zoom. Feel free to use that. We will be monitoring it for questions and things. There will be a set time to ask questions, and equally, to avoid everybody speaking at the same time, please either put your question in the chat box or raise your hand at the point where we welcome questions. As with many calls that we've had over the last few months, please keep yourself muted unless you're speaking, in order to avoid any background noise or interference. If you are having any issues with Zoom, please contact FPH. So you should have had these details in your joining instructions, but there is an email at fph.org.uk. Please email that address if you're having any issues with Zoom whatsoever. And I think the next thing to say is that we just wanted to talk about some ways of working together for this morning. Something that we've really tried hard to do is to create a safe space this morning for everybody to be able to offer ideas, to ask questions, recognizing that this morning isn't about right or wrong or good or bad, but to understand where racism exists in our system and the steps that we can collectively and individually take to address this. Please be open to learning, to understanding the perspectives of others, and also please be mindful of airtime. So if there are a lot of people asking questions, just be wary of that. On the note around a safe space, we will be writing up some discussion notes into a conference report from the event, and the addresses from Professor Fenton and Dr. Alwan at the start and the end of the morning will be recorded, but the workshops will not. And this is to make sure that we are creating a safe space in the workshops for open discussion. So on a similar note, you're very welcome to tweet during the keynote speeches at the start and the end of the morning, but equally, please do not share personal discussions or personal comments made by individual colleagues during the workshops online or with others. Again, just to make sure we have that safe space. So now I am delighted to introduce Professor Maggie Ray, President of the Faculty of Public Health, to give her opening remarks for this morning.
Thank you very much, Beth, Helen and Fatai, for getting us off to such a fantastic start. Good morning, everyone. It's a great pleasure to be here at the start of this event. And I'm incredibly proud of our future leaders in public health who have set up this important session for us today. It's been a lot of hard work for them, but we are absolutely delighted to be able to support this as a Faculty of Public Health. I really want everyone today to see this as a first step to the faculty's future work on this issue. It's certainly not a one-off. And I'm sure we will hear from many people this morning the great pain and suffering that has occurred. And I'd like to share, if I may, just two aspects for me personally. I remember many, many years ago, and probably more than 30, I worked with an amazing colleague called Albert Persaud. And I'd like to dedicate this session today partly to Albert and anyone else who's had racism in their time. And for anyone that knows Wiltshire, where I live, you'll know it's not the most diverse county in the UK. But I can still recall walking from my office with Albert into the town to get a cup of coffee, and people actually turning in the streets to look at a white woman and a black man walking down the street together. And 35 years ago doesn't seem that long to me, but that will stay with me my whole life. So we do have to see change in our society. And the second issue, I think, is another very personal one. And I suppose it's something that happens to young Black people all the time. But until it happens to you and it affects you, I think it doesn't come into your consciousness. And in our family, in the Ray clan, cycling holidays are legend. And it's lovely that your children want to come on cycling holidays. And so for the first time, we had my eldest daughter's boyfriend. And of course, we got to the airport, we checked in. I was wondering where my daughter's boyfriend was. And of course, he'd been stopped by security as a young Black man. And my daughter just took this in her stride. I was very shocked about this. And so it really brought home to me personally the way in which people are treated. And it's important for us never to forget that we have to call this out and find ways of moving this forward. We can certainly do it in our own public health practice. So a real pleasure to be here, a real pleasure to be working with everyone today. And I'm sure when we get to the end of the session, we'll be able to sum up the future actions the faculty can take. Also this morning, it's a great treat for me because I have two of my favourite speakers. I have Kevin speaking today and Nazreen. So thank you both very much for joining us today. As Helen said, we are incredibly busy in the world of public health. The pandemic has obviously affected all of our lives, and public health colleagues are very busy. So I am also very grateful that you've taken time out. So it's great that we've got Kevin and Nazreen today, but we do have such a large number of the public health family from right across the UK, and thank you for your attendance. Also, if I could also thank Samia Latif. Samia was also very much part of the planning group. So Samia, thank you for giving up your time to help us with the workshop today. So thank you, colleagues, for joining us. And I'd now like to hand back to our SPR colleagues. Thank you.
Hello, sorry, struggling with the mute button again. We'll get there by the end of the day. So it is my very great pleasure to introduce Professor Kevin Fenton, Regional Director of PHE London and Regional Director of Public Health for NHS London. Professor Fenton's biography is so vast and so impressive that it is very difficult to summarise in a few sentences. Before taking up this London Regional Director role, Professor Fenton held a joint position as Strategic Director of Place and Wellbeing and DPH in Southwark. He was previously PHE's National Director for Health and Wellbeing and also established and led PHE's Health Equity Portfolio with a range of programmes and activities focused on addressing the social determinants of health and promoting place-based approaches to health improvement. In addition to that, between 2005 and 2012, Professor Fenton was Director of the National Centre for HIV/AIDS, Viral Hepatitis, STD and TB Prevention at the US Centers for Disease Control. He's also PHE's Senior Advisor for HIV, Sexual and Reproductive Health, and provides strategic advice on PHE's health improvement programmes. As Regional Director for London, Professor Fenton will fulfil the role of the Mayor of London's Public Health Advisor, provide leadership for health, prevention of ill health, health protection, and reduction of health inequalities in the capital. Professor Fenton, I will now hand over to you. Thank you very much for joining us this morning.
Thank you very much, Beth, and good morning, everyone. Can I just confirm, first of all, that you can hear me clearly? Yes? Well, it is such a pleasure to be here. I'm now going to try to share my slides this morning. So let me just get that up. Can you see the slides?
Yep.
Fantastic. So Beth, Fatai, Helen, Maggie, thank you so much. Thank you for your leadership in putting this event on today. It is an important topic, not just intellectually, but personally. For so many of us as minority leaders, as minority workers within the system, but most importantly, for all of us as citizens of this country, grappling in the midst of a pandemic, seeing social injustice and understanding the widening inequalities that this pandemic is creating on our society. It is a time for us to both reflect on where we are, how we do better, how we be honest and authentic about many of the issues that affect our society, but most importantly, how we work together to get beyond this. So I want to begin by thanking you for holding this event. I think in my 30 years of being in public health practice, this may well be the first time that the Faculty of Public Health has certainly held a day such as this. And it's certainly the first time that I've been invited as a senior public health leader to speak on this issue. So forgive me today if the talk has a bit of personal reflection in it. Forgive me if it sometimes gets a little bit emotional. And forgive me if you leave this talk today feeling inspired, different, angry, challenged. Because nobody should be listening to these issues and not feel challenged. And no one should hear these issues without wanting to fundamentally change it. And I know that I came into public health to address the burning injustices in our societies and to make a difference in outcomes. And I think this issue justifies our focus in public health, and it justifies our actions as leaders. So for the time that I have available today, I wanted to do a few things. First of all, just to begin by reflecting on where we are. And I think, Fatai, you really did this quite beautifully in reflecting the power of what we've been through for many years in terms of minorities within Western industrialized countries, the impact of racism on the structural inequalities that we face, but the impact of racism and racialist societies on the microaggressions that many of us face daily basis. And Maggie, I think the two stories which you told earlier are really excellent examples of microaggressions that many of us who are minorities face. And yet, unless it happens to you, or unless it happens to someone close to you, it's very easy to literally walk past the things that are happening on a day-to-day basis. And this is why this session today is so important, because I'm hoping that what we will do here is to create a movement that allows us as public health leaders, as public health practitioners, to start these authentic conversations in systems right across the country. So Fatai reflected on this moment in time, a unique moment in time. Again, we're in the midst of a pandemic, and we've seen an acceleration, a peak in the issues related to race, racism, structural inequalities within our societies. And the fact that we have seen so many killings of minorities, both in the United States, has really drawn attention to the structural inequalities that are faced by minorities in Western industrialized countries. The systematic discrimination and disadvantage that many minorities face on a day-to-day basis, and how this plays out in their experiences of interacting with others in the society, as well as the opportunities that they may have to improve health and to live an effective and productive life. The deaths in the United States have been a fulcrum, an inflection point for greater global attention on racial inequalities. And certainly here in the United Kingdom, we have not been exempt from this. And although our stories of police brutality, of death in police custody, of discriminatory treatment by those in power, perhaps are not as prevalent as it is in the US or as visible as it is in the US, we have our own stories as well. We have our own narratives as well. And you don't have to scratch too deeply or too far to find those narratives. You simply have to listen. So amid much of the outrage and pain that we've seen over the past year, again accelerated by the very difficult and challenging situations we find ourselves in the middle of the pandemic. I think what we have seen is a moment in time, that inflection where governments, whether at national or local level, as well as health organizations around the world, are now beginning to affirm racism as a serious public health crisis. Now, you may ask, why does this sound so strange? Why has this not been addressed as a public health crisis before? I mean, we are very happy to talk about poverty as a public health crisis. We're very happy to talk about poor educational attainment as a public health crisis. My goodness, we're even happy to speak about the lack of sleep as a public health crisis. But somehow the narrative, the level of comfort, and the commitment that we need to name and to call out racism as a public health crisis is perhaps something that our societies are simply coming into. And this is important for a number of reasons, because when you name an issue, it allows you to address it from a place of authenticity. And when you frame racism as a public health issue, it therefore compels organizations, governmental units, to begin to address the crisis in broad and systemic ways, in much the same way that we have addressed addressing youth violence as an issue. That when you name the issue, you begin to both release funds, you begin to release leadership, infrastructure, governance to address the problem and to hold the system account for making a difference. And this naming of racism as a public health will therefore help to include and unlock strategic initiatives, including policies, practices, the way we enforce, the way we educate, and the support services. So very similar to what we have done to address poverty, very similar to the way we're addressing youth crime, and one would argue very similar to the way we're addressing sleep. So therefore, the time has now come for us to both be authentic in our language, committed in our actions in naming racism as a public health crisis. So in the time that I have available today, I wanted to do 4 things. I wanted to just do a little bit of reflection on our understanding of race and racism, and to look at its impact on health. And many of you are aware that I did work over the summer for Public Health England on behalf of the Secretary of State and the CMO, looking at inequalities and COVID. And I wanted to reflect on the patterns of disease that we're seeing and have seen over time, and how those fundamental structural issues, which were uncovered in the June report, are as live, are as prevalent, and are as relevant as they were in June as they are today. And then finally, I'll end by our thinking and perhaps some questions and challenges to you about how we embed anti-racism within our public health practice. Now, race and racism are not interchangeable constructs. And in a key part of this lecture today is being authentic in our language and understanding what we mean and meaning what we say. So when you talk about race and racism, each of these topics has its own definition, its conceptualization, the way you measure it, the way you analyze it in public health research. Now, race is a social construct. Much of my early work in HIV as a researcher examined racial and ethnic disparities in the incidence of HIV and sexually transmitted infections. And in doing my PhD at the time, I had to go back and study race theory to understand, where does this way of dividing human beings by the content, the color of their skin comes from? And what were the power constructs, the historical constructs behind it? So race is in fact a social construct. It has no biological basis, whereas racism refers to a social system that reinforces racial group inequality. Now, within many of our societies, we have gone through a process of racialization of many things, the way we view issues, the way we engage with others, the way we view and the paradigms within which we look at issues, because we begin to see things through a racial lens, and then we ascribe values to that racial lens. So racialization is a process by which meaning and value are ascribed to socially determined racial categories. And each racial category occupies a different position in the social hierarchy. Now, this concept of racism varies between societies, and the ways in which societies are willing to name and articulate race as an important defining feature is an important historical artifact, but also influences day-to-day practice and policies as well. So in France, for example, the concept of defining and dividing populations by race doesn't exist. So you're either French or you're not French. But if you are French of a North African background or West African background living in France, then you would be subject to differential treatment on the basis of the color of your skin. So the fact that there may not be a cultural, historical context for dividing individuals by the color of their skin, you will see in different societies the manifestation of racialization and racial inequalities being done in different ways. Similarly, you could look at other countries, India, Brazil, where you have multi-ethnic, multi-diverse populations, and the interplay in terms of power structures, power dynamics, opportunities, discriminatory events, and how they play out even in these multiracial and multi-ethnic societies. So when we think about racialization, then it's about how it's socialized and the meaning and value that is ascribed. And you could argue that in the US, being Black in America has completely negative implications for an individual's educational and professional trajectories, their socioeconomic status, access to healthcare services, and their ability to have optimal health. And while we may not be at the same place in the United Kingdom, we certainly can see similar impacts on Black, Asian and minority ethnic communities within our own country. And again, as public health practitioners, this should be a cause for concern. And racialization is a challenge because when you have a society which is racialized, it inevitably creates winners and losers. And within our society, we see that white lives are inherently valued over Black lives. So it's that difference which is created and how that then interrelates with the power structures. So bringing this back then to our public health language and how we begin to frame this as a public health issue, I would argue that racism can be seen as a wicked problem. We've often spoken about obesity as a wicked problem. We can speak about mental health and mental ill health as a wicked problem. And these wicked problems are complex problems that are highly resistant to solutions and are characterized by high difficulty and disagreement about the nature and cause of the problem, as well as the potential solutions. Now, we should also begin to frame racism within the language of public health. So not only is it a wicked problem, but we should be viewing it as a fundamental determinant of health. And that's because the processes which generate and sustain racism endure and adapt over time. And because racism as a system of power imbalance and disadvantage influences multiple mechanisms, policies, or practices within the country, and ultimately has a huge impact on health and health outcomes. In the presentation today, we're going to be reflecting a little bit on the health consequences of living in a racially stratified society. And we see these differences both in how we measure health, how individuals are able to access health, the quality of care that they see, health outcomes, and of course, ultimately mortality. And you see this stark. It has been described for many years in the United Kingdom, and it's been brought into clear, crystal clear realization with our experience with the COVID pandemic. So racism itself is a public health issue, I would argue, and we need to get comfortable saying that phrase. Racism is a public health issue. Racism is common. We know that between 25 to 40% of participants in surveys in the UK would say, are happy to say that they would discriminate based on an individual's ethnic background. We know that a third, an increasing proportion of minorities within our country constrain their lives through fear of racism. And we know that we've seen a year-on-year increase in hate crimes in our country, the majority of which are racial. And we've seen year-on-year increases over the past decade. We know that we see disparities in between Black and ethnic minority groups and majority groups in a range of social issues within our country, from housing to education, your likelihood to be stopped and searched, from court sentencing. And the challenge that we face as leaders is how to not let this be background noise. How do we remove the scales from our eyes so that we begin to see these issues anew? And in the same way, we would be angry about rising levels of poverty, rising levels of people needing to go to food banks to survive. We should be able to bring that same passionate, evidence-informed, as well as strategic actions and skills to addressing and naming racism as a public health issue. So what do we know about racism and health in the UK, and how does it manifest itself? I wanted to really look at what other agencies have been saying and how this has been described. It's nothing new, but somehow, again, we feel much more comfortable speaking about other domains and other structural inequalities rather than naming and calling out and addressing racism. So the Race Equity Equality Foundation in 2007 defined racism and the issues around racism around the poor treatment that minority groups receive due to the negative attitudes of others regarding their character or their abilities. And as Maggie shared in her stories, this is not only about the sort of individual interactions you may have, which people may have a negative feeling about, but it's the pervasive and persistent day-to-day interactions with other people where the microaggressions can have a huge impact on your mental health, your well-being, and ultimately your physical health as well. But in a racialized society where racism is not spoken about or addressed, then the systems of power, this distribution of resources and the inequalities that drives results in the development that may negatively impact the development of effective policies to reduce disadvantage. The Health Foundation more recently in 2020 spoke about racial discrimination affecting people's life chances negatively in many ways by restricting access to education and employment opportunities, thus resulting in poorer outcomes, for example, socioeconomic circumstances. And again, linking racism and stress, and that stress being a direct correlation to the poor mental and physical health. Now we see the manifestation in this more society as we become even increasingly diverse. And you would hope that as diversity increases within our society, many of these issues would be much more easier to be called out, easier to be addressed, and a more honest conversation would be able to be had between us all as we live in a far more diverse community. So we are an ethnically diverse population. The proportion of people identifying as white is decreasing and has decreased over the past few decades. But we know that there are differences across ethnic groups, and we'll have a look at some of these in subsequent slides. We see significant differences across ethnic groups in people's life chances and quality of life. In some areas, the inequalities are decreasing, but in many, they're either static or increasing. And when you think about the racial disparities and you layer on Professor Sir Michael Marmot's work on income inequalities and the worsening of the sort of gap over the past 2 decades, then you see how and why Black, Asian, and minority ethnic communities are doubly disadvantaged by some of the realities and contexts of living in the UK in the 21st century. Cultural. They can reflect structural patterns in how communities are located within society, the opportunities that they have, the structures of their households, the way they mix socially, and the way they interact with the ethnic majority. And all of these factors can have a huge impact on both disease transmission as well as disease vulnerability and the likelihood of having a positive health outcome when faced with a mental or physical health challenge. So again, looking at some of the data, we know that there are substantial differences in the ways in which Black, Asian, and minority ethnic communities are able to participate in the labor market, with higher levels of unemployment seen among Black, Pakistani, Bangladeshi, or mixed race individuals compared to whites. Again, with the COVID pandemic, we know that Black-owned businesses, both in the US and here in the UK, have taken a particularly hard hit. And as we emerge from wave 2 of the pandemic, we're likely to see fewer Black-owned businesses than we did at the beginning of the epidemic. We know that within race, we have significant differences by age and by gender. So the concept of intersectionality, especially in employment, is important because your economic well-being is going to be a key determinant of your physical and mental well-being. And so that intersection is also important as well. For many minority communities, they may have higher rates of self-employment, but even within that, you see differences in average hourly pay. So therefore, even owning a business may not provide you the economic and the health leverage that you would expect if you're a member of the white majority because of the economic disparities which exist as well. We know that there are significant differences in housing. So households that are most likely to rent social housing were headed by someone of African, Caribbean, other Black, Bangladeshi, Irish, and Arab groups. So most BME communities within our country. And we know that ethnic minority communities are much more likely to rent privately than white British households and to spend a higher proportion of their incomes on rent, regardless of whether they rent from a social or private landlord. The other key factor which is important for us to understand health and the distribution of ill health within the society is that the housing that BME communities are likely to be in tends to be of poor quality, especially households of Pakistani origin, and overcrowding is more common, especially in houses of Bangladeshi origin. And overcrowding, as you know, affects BME communities disproportionately, and London has one of the highest rates of overcrowding in all regions in England. So from these 2 slides alone, and looking at our experience with COVID, you can begin to see how some of these social and structural factors, which are mediated by and through race and racism, begins to impact the vulnerability of communities towards acquiring COVID and to have negative outcomes from COVID. And whether it is COVID or you're looking at wider health inequalities, I think the data are stark and they are clear, and one would argue that they really haven't made much progress over the past 2 decades. We see differences between ethnic groups in a range of health-related behaviors, from prevalence of overweight, obesity, prevalence and incidence of non-communicable diseases. We know for many infectious diseases, we may also see significant variations in the prevalence and incidence of disease, whether tuberculosis, HIV/AIDS, or other conditions. And certainly COVID has joined the list of infectious diseases where we see significant inequalities across groups. So these inequalities then have really been brought into stark realization with the COVID pandemic. And for those of you who've heard me speak about this before, I often begin by saying that COVID didn't create inequalities, but it certainly shone a light on inequalities within our country, and in many circumstances really has exacerbated those inequalities. And a key part of preparing for the second wave is beginning to think through how we mitigate the impact on the most vulnerable within our communities. And we begin to think about what does recovery after wave 2 looks like, so that we begin now to engage communities to think about the support structures, the resilience that will need to be rebuilt and accelerated as we go through the pandemic and of course emerge on the other side. So again, in the summer of this year, we were able to look at health inequalities and COVID. We undertook both an epidemiological review as well as a wide stakeholder engagement exercise involving more than 4,000 individuals over a 6-week period to both reflect on the experience of COVID in the first wave, to understand the drivers of inequalities in COVID, and to begin to chart the way forward, hearing from our stakeholders, looking at the evidence and understanding the epidata on and what were the most impactful interventions that could be put in place to mitigate the impact of COVID on minorities. Now, the data from a review in June of this year were stark. It really showed significant geographic heterogeneity, differences across gender, differences by a range of demographic as well as behavior characteristics. But some of the most powerful differences we saw are highlighted here. Differences in COVID mortality rates. And again, this was in the first phase of the pandemic where we saw significant geographic clustering. And of course, a very strong relationship between deaths and COVID and its association with deprivation, with those living in the most deprived parts of the country having significantly higher death rates than those in the least deprived. Unsurprisingly then, we saw COVID emerge as a pandemic on the back of widening inequalities within the society as described by Michael Marmot, but also vulnerabilities across our ethnic groups, which have been pre-existing and predated the COVID pandemic. Consequently, we saw these significant differences in ethnicity death rates at that time. And again, remember that this was the first phase of the pandemic when most of the tests which were being done were among individuals who were attending healthcare services with moderate to severe disease. But the data from PHE were absolutely clear that looking across racial and ethnic minorities, whether male or female, there were significant differences in the likelihood of dying from the disease if you were a minority individual, with the risk of death being between 10 and 50 times higher among BME communities compared to white British ethnicity. And that's even after adjusting for age, sex, deprivation, and region of residence. So very stark features in terms of the differences that we have seen in the first phase of the pandemic. And these findings were replicated by studies from the ONS as well as other academics. But the first phase of the pandemic is over, and we had a summer to prepare, to engage, to empower, and to learn from the first phase of the pandemic so that the impact on minorities, the impact on the most deprived in our communities would be mitigated. Well, how are we now? Well, this data just looks at some of the positive cases with specimen dates up to the 19th of September, and we can look at some of the most recent weeks of reporting. And you can see many of the factors in terms of the disproportionate burden on some ethnic groups being persistent in the data that we're seeing today, with 10% of positive cases in the most recent weeks being diagnosed among individuals who are Pakistani, Asian or Asian British ethnicities, as well as a relative 5%, 6% in Indians, as well as increased diseases seen in other BME communities. And when we adjust for population size across the ethnic groups, looking at the cumulative number of and rates of Pillar 1 and Pillar 2 COVID cases, you can see the stark differences in rates of disease across these Black, Asian, and minority ethnic group, with particularly high rates of disease seen in Indians and Pakistani British, as well as the other ethnic group, which, as many of you know, may be an artifact of reporting or non-collection of ethnicity data. We can look at some of the more recent trends, and you can see that certainly as the epidemic had resurgent disease over the summer, we saw a very high clustering of those initial cases within BME communities. And as the epidemic has once again become generalized and is accelerating in many regions of the country, we're seeing proportionately greater amounts of white British individuals being affected. But again, by week 34, 33, we saw nearly 50% of all cases being in minority ethnic communities, with again that disproportionate burden of disease among Pakistani individuals in the country. And again, these disproportionate rates of disease are really drawn into sharp focus here, where the weekly incidence per 100,000 population by ethnicity demonstrates the pervasive hyperendemic levels of COVID that we've seen, especially in Pakistani communities, as well as the acceleration of the epidemic within minority communities across the country compared to white British. In this slide, the white British population is in the navy blue. It's the second lowest rate of weekly incidence in the country at this time. When we adjust for population size, you can see that the vast majority of minority communities are disproportionately affected by incident infections with COVID. And we see this disproportionate burden of disease irrespective of age. So you can see for Pakistani communities on the upper right-hand side of this graph, the very high burden of infection, which we see across most age groups, followed by Indians, and then of course, the pattern which you see in other ethnic groups, with relative sparing of that wide distribution and impact of hyperendemic infections ethnic groups at this time. But I'd also draw to your attention at this time. Finally, we could look at geographic area of residence. And again, you see differential patterns of hyperendemic levels of disease transmission, much of which reflects where the infection was endemic at the end of lockdown in July of this year, the patterns of social and structural drivers of the epidemic within many of these societies, and where the infection both took root and then accelerated over the summer and over the most recent months. Some of the most marked features in this slide, which is looking at positive cases by ethnicity, by region. You can see the patterns in the Northeast and the Northwest regions, which have seen the rapid increase in infections. And then more recently, you can see the disproportionate transmission occurring in most areas. And again, the disproportionate burden in Pakistani communities. Now, PHE's review of the impact of COVID on inequalities and specifically on BME groups, Black, Asian, and minority ethnic groups, really unpacked qualitatively some of the social, cultural, and structural factors which may well explain not only what we saw in the first wave of the pandemic, but which continues to have an impact today. Now, I won't have the time to go through all of these in detail, but suffice to say that one of the key factors which were highlighted by members of the public, by professionals, by civic leaders, as they reflected on the first wave of the pandemic, was not only the factors that drove long-standing social and economic inequalities, or the factors that increase the risk of exposure to COVID, or the factors that increase the risk of complications and death of COVID. But there was much interest and much discussion and much dismay that the role that racism, discrimination, stigma, fear, and mistrust may have played in both the patterns of the disease that we saw in the first wave of the pandemic and how that could influence subsequent waves of the epidemic. And in the report, we talk about the need for more culturally competent interventions, ensuring that we're not leaving communities behind, either in the way we make decisions or the ways in which we communicate those decisions and we support communities to protect themselves, their communities, and their loved ones. We heard stories from our stakeholders about differential access to PPE and how racism structural issues influenced both the agency that minority individuals had to request appropriate risk assessment and protection, and their ability to feel that their workplaces actually valued their lives equally to their white colleagues. We heard heart-wrenching stories about the role that stigma and fear of COVID played in the first wave of the pandemic, and how that in turn negatively impacted health-seeking behaviors, or the permission that people felt they had to call 111, to argue with the operator, to get the treatment and care that they need. It also influenced late presentation to services, because if you don't trust about going in to be diagnosed, to subject yourself to what you think may be inferior or poorer care. And of course, this wasn't helped by the narrative which was going on at the time in the media, which often spoke about or spoke to the disproportionate impact on minorities and why this may happen. Narratives of people not behaving themselves, narratives of people not adhering to guidance, narratives of, well, it may reflect other factors which, we wouldn't want to talk about, but, it's there. And that role of the media in both framing and shaping stories, but also perhaps hindering the ways in which minority communities would engage with the system were important. So in the presentation and in the work that we did over the summer, stakeholders really stressed that in any understanding and in any truth and in any authenticity in addressing the COVID epidemic, we have to consider racism as causative. And that will be an important step in both defining the research agenda and informing the way we deliver and implement our health services. Because when you begin to frame this, not thinking of individual determinants of health, but as a structural issue and as a public health issue, then it moves the discussion away automatically from simply looking for biological differences towards the issues that really matter. Who has access to services? What and how are preventive interventions delivered? And how do we really deal with some of the issues that we discussed before, such as overcrowded housing, poor job opportunities, having to go out to work to put food on the table in the middle of lockdown? And when you investigate the range of factors which are driving risk for COVID, if you're approaching this from a process of understanding racialization and the importance of racism, then you begin to ask different questions about why is there a higher likelihood of severe disease or poorer outcomes for COVID or any other conditions, and what role might perceived racism play in the development of these differences and its persistence. Stakeholders also felt it was really important for us to name and address racism because of racism's pervasive psychological, pathophysiological, and cognitive impact, and how that can negatively impact how people listen to, hear messages, engage with messages, and want to be part of the solution. And that having this deeper conversation about racism as a structural issue could have tremendous benefits for us as we think about the response to COVID at a structural and individual level. So I'm coming up now to the final few minutes of the talk, and I wanted to end by just reflecting on anti-racism. And this is an important topic because it's one thing to recognize that racism exists and to talk about it as a public health issue, but it's something else to take a much more proactive stand on what we intend to do collectively to address this. Now, like many of you, this concept of anti-racism is relatively new. It's gaining additional steam, again, as global awareness of this issue has increased. Anti-racism is the practice of identifying and challenging and changing the values, the structures and behaviors that perpetuate systemic racism. It is a way of being much more proactive. It's a way of seeing and being in the world in order to transform it. And this language, I think, resonates with, I'm sure, all of us as public health practitioners. The good thing about being anti-racist is that it's a conscious effort. It's a conscious effort and it drives actions that will enable equitable opportunities for all people, both individually and systematically. And anti-racism is now increasingly used as a frame in policymaking, in education, and I think now is the time for us to begin to think about the opportunities for us in public health and perhaps to lead the medical fraternity in our understanding and actualization of actions to address anti-racism. Now, anti-racism is important because it is both proactive and because racism occurs at different levels in society, it provides us with a frame to address issues in a more holistic way. And part of that is being honest about how racism affects the lived experiences of people of color. Part of it is being honest about the systemic, pervasive nature of racism and the fact that it goes between generations, it goes between societies, and has a vested interest in perpetuating itself. And it allows us to speak about privilege and the concept of white privilege within a safe way, recognizing that whites may unknowingly participate in racism, including the concept of whiteness without even recognizing it, and how whiteness shapes both their actions, their views of place in society, and their willingness to act on issues of racism. So anti-racism may well provide a safer space and a safer structure for us to deal with some of these difficult issues. But what does it mean for us practically? CIPD has developed 6 principles to address anti-racism in organizations. And I thought these were really helpful to go from the theory into the specifics. And in Public Health England, working with our BME staff group, who has challenged us as an agency to do better and to go further and faster in addressing racism and anti-racism as an organization. There are many of these key principles which we're now looking at implementing or have implemented in PHE, but I would argue that more needs to be done on this as well. So clarifying the organization's stance and values, having zero tolerance for racism, being clear about our expectation as an organization on this issue. The fact that we need a systematic approach to addressing this, and it has to be a sustained approach as well. It's not something done over a financial year and then written up in an end of year report, but it's something that should be pervasive within the culture of the organization. It requires visible leadership and not just of the chief executive of the organization, but from every leader in your organization. And we know that in many organizations, it is middle management that perhaps has the workplace well-being, influences employee mental health, and has a huge impact on creating environments which are anti-racist. It has to be integrated in our people management approach, so we have an end-to-end approach for addressing these issues. And as you're doing today, we have to create safe spaces and systems, as well as time to talk. Sometimes those conversations will be hard, but only through having those tough conversations will we get to a place of authenticity and difference, which is what I know everyone wants. And finally, the importance of communicating and sharing as we're doing, so that all staff members, all partners understand the journey that you're taking your staff through and your organization through. And we have a time to check in with our partners, to check in with our staff to ensure we're on the right track. So colleagues, I've come to the end of the talk now. It's hard to believe that in 30 years of practice, this is my first talk on racism. So for Ty, Helen, and Beth, a huge thanks for allowing me the privilege just to reflect a little bit, to share with you as leaders about what this means and what this means to me. If nothing else, I hope you've taken away that racism is pervasive, it permeates our everyday lives. Addressing racism is central to addressing disparity, and being comfortable with this as a public health crisis, and to integrate this into our agenda. And by doing so, to measure it better, to address it better, to develop interventions that work, and to ensure that we're making that difference. So in closing, I ask, what will you do next as a result of participating in this? I hope that you will, as young public health leaders, argue for a fundamental relook at how we train and how we integrate this issue into our training moving forward. I hope that those of you who are academically inclined will continue to push for this issue being funded and being understood at the level and magnitude that it needs to be by our research funding bodies. And for those of you working locally and in contact with communities, that you will think about the community advocacy agenda, because I can tell you this, there's nothing more engaging, there's nothing more inspiring, and there's nothing more authentic than when you have these conversations with disaffected communities to say, I see you, I understand what you're going through, and I'm going to be honest with you in helping to make that difference. Colleagues, thank you so much, and I hope we have a few minutes for questions.
Kevin, thank you so much. That was an incredibly powerful talk, and I think the perfect way of opening this morning's session. And also thank you so much for making it so personal. I think that really adds to the power of what you were saying. So we have approximately 15 minutes for questions. We are already getting some questions through in the comments. So I'm just going to start by going in chronological order through those. So the first question to you, Kevin, is from Abby. Can you please comment on the way we measure racial inequality through the categories we use? PHE uses BAME. Yes, historically, this is a term used to describe similarities in disadvantage for people with these identities. But is it not hindering the way we measure and therefore tackle inequalities because we are homogenizing so many different identities? And is this term not adding to the fact that whiteness remains unacknowledged and nameless whilst referring to these groups in relation to whiteness?
Great, so thank you. Who asked that question, sorry?
It was me, I'm Abby.
Abby, hi. Oh, good. Thank you for putting the camera on, Abby. And we might as well try and meet each other while we're doing this. So Abby, I agree with you. In one sense, we're doing much better in terms of racial and ethnic monitoring than many of our Western European counterparts, in part because of our historical use and racialization of our society. Nevertheless, it leaves us with very blunt tools. And it also, as you say, sets up a dichotomy between whiteness and whites versus the others. And what we do, therefore, is not only lump ethnic groups and ethnic subgroups within these broad categories, but we're often very lazily not thinking about the differences within the white ethnic group. And that comes around to bite us all the time. So, if you look at the COVID pandemic, by looking at whites homogenously, we missed in some areas, I would argue, emerging epidemics in white Eastern European migrants.
Yeah.
You miss other white groups, whether by social class or economic class or levels, that allows you to say, actually, within the white group, there are different epidemics which are occurring, which may well be mediated by other social and structural determinants. So you therefore disadvantage everyone by using these blunt tools. So do we not do it because it's so bad, or do we try to improve it? I would argue that we try to improve it. And that is exactly the reason why when we did the research over the summer on the impact of COVID and inequalities, I was so keen to combine the data, the epidemiological review, with the stakeholder qualitative review, as well as a wider literature review, because you have to look at different perspectives on these issues. And you have to use the power of qualitative research, of narrative, to go beyond the data and beyond these sort of broad epicategories. So Abby, thank you. Completely agree. And great question to get us started.
Thank you.
Okay, so I've got a next question from Kazim. On the psychological points you made in pushing progress on racism in the UK, there are often moments of immense frustration that minorities experience. How would you recommend maintaining motivation to keep pushing and maintain a psyche that isn't cynical, but is calm, open and progressive when you face barriers in your work? Perhaps Kazim can put on camera so we can...
Right, so who asked that question? Can I see your face, please?
Can you see me?
I can see you now.
Yes,
so Kazim, thank you. You're absolutely right. In preparing this talk, I have to say, I did so much reflection about my own journey over the last 30 years. And why is it that we don't think twice about naming other social and structural determinants, but somehow we're afraid to name racism? And I reflected on my own timidity in naming racism and why that needs to change now, and why, following the work that I did over the summer, this situation that we're seeing ourselves in, we need as practitioners to begin calling it out, and we need to let those words trip off the tip of our tongue. And Kazim, that's important, because if we as leaders are not willing to name an issue, then it means that we give credence to it being swept under the rug. And if we are not willing to take the risk to say, by naming this issue, you may feel uncomfortable, research funders, you may feel uncomfortable, chief exec of a local authority, but this is the right thing to do, and here's why. And I think, Kadeem, what I've learned over the past 3 decades is in trying to create a shift in how we conceptualize and how we respond to a very difficult issue. Doing that on the basis of data is important. Recognizing the power that you have of narrative to help to shape and to provide the understanding of that data, and demonstrate the potential impact that it could have if you're able to address it. So the way we frame racism as a public health issue cannot just be that we do that as an end in its own right. It must be to say, if we do this, then this is what's likely to happen. And this is how you as an organization, you as an individual will be able to benefit from that. And creating that narrative arc, I think, is going to be important as well. And in the last, in my own practice, we've used that in the 90s when we're trying to frame issues around Black Africans and their risk for HIV in an environment where there was a strong anti-migrant sort of context that we were working in. We're doing it today when we think about youth crime and how we begin to frame youth crime not as a problem of young Black boys in the inner city, but as a product of a racialized society which demeans and devalues the lives of young Black men. And therefore the solutions that we need to look at are not just stop and search, which is in fact a lazy intervention, but it is in fact addressing the long-standing issues and having longer-term approaches. So Kazim, I think it's about using data, it's about bringing leadership and partners along with us, and it's about showing them what might obtain differently by taking this approach as well. Hope that helps.
Thanks.
Brilliant. Okay, so the next question we have is from Venikai. Thank you, Kevin, for your presentation. I was wondering, following the Beyond the Data PHE review and recommendations in mitigating the disproportionate impact on Black, Asian and minority ethnic communities, will there be a follow-up review to this that will be widely published to learn the lessons that were applied during the pandemic, how we continue to build on the lessons post-pandemic, and to keep this matter on the public health agenda nationally?
Hi, Venikai. If I could see you on camera, that would be great. If you're happy to show your face, I would love to do a second review, or more importantly, have it done by independent academics, so that we have an even more robust assessment of where we are. And I would argue that this should form part of what we do moving forward in using this as a totemic moment to look at the impact of racism, social and structural determinants on health. And it is important, Venikai, for us to do this because we're moving into the second wave. The report was published in June. In July, we began seeing resurgence in the Midlands, in Leicester, and then throughout August, we began seeing it in the Northwest and Northeast. So in a sense, implementation, there wasn't a period of perfect implementation where we waited for the second wave. In fact, it was actually the data were published and almost immediately the key recommendations began being used and implemented. Today, we have much more culturally competent messaging on for a range of COVID interventions. We have better data now on testing and contact tracing outcomes by race ethnicity. We have developed a range of interventions which are supporting the social and structural determinants and factors for people who are disadvantaged and how they operate. We have organizations such as the NHS, which have released the phase 3 letter, committing as a National Health Service to address inequalities and to improve the experience of BME workers within that organization, and to commit to much more diverse leadership as they move to the next phase of both the pandemic and the NHS's evolution. So there's been a lot that has happened, and I think we do need to capture this, but we also need to ask ourselves what more can be done, and what were some of the barriers to implementing the recommendations, so we can again continue to learn. My final point, Venikai, and you may probably heard me say this before, I was deliberate in that report in only putting 7 recommendations down. Now, some argued, oh, you should have had 50, 60 recommendations and really, sort of be specific. And my thinking was, the last thing, organizations that are in the middle of a pandemic need to be grappling with is a report with 50 recommendations. We've had those before. But what we wanted to do is to have a few key recommendations which were implementable, scalable, acceptable, appropriate, and had impact in helping to mitigate the impact on the epidemic, both the current one and subsequent second waves. And that's exactly what we focused on. And by focusing only on 7 things, I would argue it has allowed us to move a little bit faster and to hold the system to account rather than getting lost in a lot. So, Venikai, a bit of a long answer there. I'm sorry, but it's just to say I agree with you. I think it should be done, and I'm hoping that whoever does it will let me know that they're doing it too. Thank you.
Thank you. We have time, I think, for just 2 questions, so we're quite quick. The next one is from Rob H. Anti-racism is seen as political in the current climate of culture wars. How do we ensure the formalised naming of racism as a public health issue isn't seen as another left-wing plot? We're in a time where white supremacists are forgiven or condoned by prominent populist leaders, and minorities in other countries such as India are seen as fair game.
It's a really good challenge, and I think that's why having professional bodies, having white British leaders who are in position of power to become allies and to be anti-racist will be part of changing the narrative or challenging the narrative. The power of the Faculty of Public Health hosting an event like this, the power of the BMA holding events such as this, means that if the professions are aligned in addressing this as a social issue, then that changes the narrative, and it also enables us to at least have a countervailant narrative to the ones that you described that are perhaps prevalent at the moment. Because if we don't do that, then in fact there's no pushback. there's no countervailant argument that says, actually, this is wrong. This is not the new norm, and this is not acceptable. And that it is causing irreparable harm, not just for this generation, but subsequent generations. So I think the role of allyship is important. The role of leadership is important. The role of organizations and professionals addressing this is critical to help to do that balance and to ensure that the narrative and the lexicon related to this continues to change.
So I think we've got time to squeeze in one more question. I'm really sorry to the others who've also asked questions, but the next question we have is from a Beret. Kevin, could you comment on the use of the recent trend of using the last emotive word disparities rather than inequalities?
Yeah, so I know that for some individuals, that for some colleagues, that there's a real tension in using disparities and inequalities. In my own practice, because I have worked in the US and I've worked in the Caribbean and Europe and here in the UK, I tend to use the language interchangeably but they're not. They're not interchangeable. And I know that this is important for us in terms of defining language and what we are wanting to do. The key thing I think to remember is the importance of narrative and understanding that governments often frame things in different ways. And in my own, and I know Maggie will know this, in our own practices over the past few decades, we've seen governments where you're not allowed to use the term inequalities, that variations were the term that was acceptable to the political colleagues at that time. And that framing and the use of language can be equally important in both naming an issue as well as a sense of urgency that it obtains. So yes, thank you for pointing that out. I think in the United Kingdom, we tend to talk more about inequalities and the framing around inequalities, but do bear in mind that there's a context within which the language sits, and that the acceptability, your ability to move forward with interventions, often requires you to begin thinking about how best to frame an issue for impact. So great question, and thank you.
Oh, thank you very much. So I just want to extend my thanks to Professor Fenton for coming today. It was really fantastic, and also to everybody for giving so many amazing questions. I'm sorry we couldn't get through them all. I'm just going to hand over to Fatai, who's going to show us what we are, he's going to give us some instructions for what to do next.
Thank you, Helen, and thank you, Professor Fenton, for that amazing session. Can I just ask if Beth can bring up the slides on the breakout groups, the workshops for the rest of the morning?